Welcome to Let's Have a Heart to Heart, Reducing Your Risk for Heart Disease. This program is brought to you by the Sima Boesky Heart Center at Northern Westchester Hospital and the Center for Healthy Living. My name is Melissa Hernandez, and I will be your moderator tonight. I'm a physician assistant in the Cardiac Catheterization and Electrophysiology Lab. With us tonight, we have two Northern Westchester Hospital cardiologists, Dr. Carl Reimers and Dr. Subharat Chaudhry. Tonight, Northern Westchester Hospital's doctors will be talking about common myths surrounding heart disease and the latest advancements in cardiac care within interventional cardiology and electrophysiology. Plus, we will take you on a virtual tour of the Sima Boesky Heart Center and our state-of-the-art cardiac catheterization lab. As time permits, at the end of the program, we will take questions and answer some of your pre-submitted questions from registration. Please put all questions in the chat or Q&A function. If your question is not answered during the presentation, please feel free to put your question in the survey at the end. At any time during this presentation, if you are interested in booking a consultation, please private message us in the chat function with your name and contact information. One of our providers will contact you for assistance in answering your questions or for booking a consult. You can also provide your contact information in the survey at the end of the program. Your contact information and name will be kept confidential. To schedule a consultation with Dr. Reimers or Dr. Chaudhry, please call 914-242-9400. Let's get started. I would like to introduce Dr. Carl Reimers. Dr. Reimers is the director of the Cardiac Catheterization Lab at Northern Westchester Hospital's Cardiac and Northwell Cardiology Service Line Director for Westchester County. Dr. Reimers, welcome, and please tell us about the Sima Boesky Heart Center at Northern Westchester Hospital.
So the Sima Boesky Heart Center is a comprehensive heart center where we are involved with clinical cardiology, interventional cardiology, electrophysiology, preventative health, women's cardiovascular health. It's a wonderful thing. The Cardiac Catheterization Lab opened on September 2nd, 2020. And we have two labs, and thus far have done just shy of 1,000 cases. And so it's been a wonderful, wonderful experience. And, we're excited, Dr. Chaudhry and I are excited to sit here and tell you a little bit more about how you can prevent yourself from getting to see us in a cath lab or electrophysiology lab.
Excellent. So what are some cardiac issues that you see and treat?
Well, typically what we do is we treat patients who have blockages. Dr. Chaudhry will talk about, electrophysiology. I like to think of cardiology as a combination of plumbing and electricity. So I'm a plumber, he's an electrician, both very important. Typically patients who present with chest discomfort when they're exercising or shortness of breath, and they have some evidence that they may have a blockage in one of the arteries of the heart will come and see us. I think most importantly, what our lab does for the community is we provide access 24/7 every single day of the year for somebody who's in distress. So somebody who comes in having a heart attack, we can take care of them right off the bat. That is a truly life-saving thing. The Mount Kisco area, including Katona, Chappaqua, Bedford, Armonk, you really would end up, if you call 911 having a heart attack or thinking you're having a heart attack, you're going to Valhalla or Connecticut, either Danbury or Stamford. And this is a way to prevent that 30-minute ride to one of those locations. And we have a saying that time is muscle. So when somebody is having a heart attack, it is imperative that we get to them as soon as possible. We have a mandate, which is 90-minute door-to-balloon time, meaning that from the moment they enter the hospital, the diagnosis must be made, and then we must have the artery open and blood flowing down the artery within 90 minutes. If it takes you 30 minutes or more to get to the hospital, then that just adds time. Ideally, we want people to have the artery open within 2 hours of it being closed down. So that's the biggest advantage to our community, is to offer a service that has never been offered before. We've done many heart attack patients since opening, all successes. And so it's very, very exciting.
Absolutely. I explain what are some cardiac warning signs that patients can kind of be made aware of, so they have an idea of what it could be if they're having a heart attack.
So the classic sign is a patient who describes an elephant on their chest or a weight on their chest. So if I hear somebody say, I'm having, chest pain, and by the way, it's right here and it's sharp, that is not heart pain in general. Okay, it could be something like pericarditis, which is a benign disorder, but heart pain classically feels like a weight on your chest that may radiate down your left arm into your jaw. It may be associated with shortness of breath, nausea, profuse sweating. But the problem is, and this is especially true with women, is that it can present other ways too. There are a number of patients who show up just complaining of epigastric pain. And, Melissa, how scary is that? I mean, how often do you go to a restaurant and you leave and you feel a little epigastric pain, right? And the key is, if you take an antacid for that epigastric pain, it's not going away, then maybe it's something else. And I'm not trying to scare everybody because that's not my point, but it can present other ways. And also, I think there's a great debate about women typically present with different signs of heart disease. And it really takes the cardiologist, you need to have acute awareness that women often present differently than men, and diabetics, by the way.
Absolutely. Thank you for that. So what are some tips to stay heart healthy?
Well, basically know your risk factors. So risk factors for heart disease are number one, genetics. So if your mother or your father had heart disease at a young age, so typically that is your father had heart disease at 50 and your mom had heart disease at 60, that's a risk factor. Unfortunately, there's really nothing you can do about that. Genetics is genetics. It is a risk factor. Just because your mom and or father had heart disease does not mean that you will necessarily have heart disease. The genetics are very, very murky. It's not streamlined in the sense that, oh yeah, my parents had it, so I'm going to have it. I frequently see patients who show up at age 50 with heart disease and their parents are totally fine. Right. Somewhere down in the lineage, great uncle, whatever, had heart disease and that passed on to them. So not much you can do about that. High blood pressure is clearly a risk factor. High cholesterol is a risk factor. Obviously, maintaining your weight is important because that will lower your cholesterol as well as your blood pressure. Don't smoke. At least don't smoke cigarettes. Stay active. Being active is so important, not only for heart disease, but for so many other things. We talk about getting enough sleep, managing stress. We honestly don't know enough about this. Stress is part of life. And there are some people who can handle stress and, their pulse rate barely goes up. And there are other people who pulse rate goes sky high, their blood pressure goes sky high. I mean, it's tough to answer that question. We don't have good answers, that way. And then clearly seeing your doctor on a regular basis. If you're, honestly over 40 years old, you ought to be seeing your internist once a year. And if you have lots of risk factors, maybe you should be seeing a cardiologist too.
Excellent. Thank you so much. So as we segue into our virtual tour, we had one question in the forum asking who is Seema Boesky. So I figured you could answer that question before we go into our little tour.
Seema Boesky is a wonderful charitable woman. I've had the honor of meeting her several times. She lives in the community. She cares deeply about Northern Westchester Hospital. She has contributed not only to the cardiac cath lab, but also to other aspects of the hospital. She is just a wonderful, wonderful human being. And I just can't say enough about her. Every time I see her, I'm just awed by her poise, her grace, her drive, her intelligence. She's just a fabulous person.
Absolutely, absolutely. So with that, we'd like to transition into giving you a tour of the Cimabowski Heart Center and Cardiac Catheterization Lab.
Now that we have the cardiac catheterization lab at the Cimabowski Heart Center, we're able to very quickly take care of the patients in this immediate community in a way that they have not been able to be taken care of in the past.
The more common emergency that we encounter in a cardiac cath lab usually has to do with the heart attacks. They'll be able to come in as quickly as possible. We'll be able to stabilize them.
We've been able to shift to a minimally invasive approach for many cardiac pathologies that we did not have options for in the past.
We have this saying in cardiology, time is muscle. And when you talk about it, we're talking about the heart muscle. If we're not able to open up that artery within a certain amount of time, that part of the heart can actually die off and never recover.
We have a team ready to receive a patient within 30 minutes of being called. Often we will bypass the emergency room and have the patients brought directly from the ambulance right up to the cardiac catheterization lab because you're really saving a lot of time. No longer do they have to go further distance, such as to Manhattan or even the state of Connecticut, to get the definitive heart care that they need.
We're able to keep the same high quality level care within the community close to home.
This cardiac catheterization lab is an extension of Lenox Hill Hospital, which has a worldwide reputation for advanced cardiac care.
Patients will have access to top cardiac physicians from all specialties.
We are providing care directly to patients, but at the same time we have the backup of the entire infrastructure at Lenox Hill that's developed over the last 20 years. It's great that the community gets to receive that world-class care right in their backyards.
Excellent. We hope that you all enjoyed that video. Welcome, Dr. Subbarao Chowdhury. Dr. Chowdhury is the Director of Cardiac Electrophysiology at Northern Westchester Hospital. He will be speaking to us about the new electrophysiology program and lab. So Dr. Chowdhury, welcome. If you could start off by briefly describing the heart's electrical system.
So thank you. I think a lot of you are familiar with a lot of the stuff Dr. Reimers has talked about. And what we do as electrophysiologists is work hand in hand with our interventional cardiologists. The electrical system, so the heart is a big pump, and Dr. Reimers and his team deal with the arteries that supply blood to the pump. But the pump is coordinated by an electrical signal that coordinates where the upper chambers beat and then the lower chambers beat to keep blood moving. To keep blood moving, but also make sure it's moving efficiently and effectively. And the electrical signal can go haywire in various ways. That's what I deal with, and that works hand in hand to keep everything working as efficiently as possible.
Excellent. So what do you treat? Abnormal heart rhythms, and what does that mean?
So abnormal heart rhythms or arrhythmias, which is the same word. So basically is your heart, everybody's heart has its own electrical signal, which responds to different cues. So if we are sleeping, our heart is going slower because it responds to the sleeping hormones and hormonal cues from that. If we're out running or running away from in prehistoric times, it was running from a lion. But now if you're stressed out or exercising or whatever it is, your heart rate increases appropriately. And that's the normal heart response. There's various ways where that heart response or heart signal can be abnormal, and that can result in either abnormally slow heart rhythms or abnormally fast heart rhythms. And both of those can be bad in various ways. So for abnormally slow heart rhythms, we put in devices called pacemakers, which help to give an artificial electrical signal to replace the heart's own electrical signal. And for abnormal fast heart rhythms, there are various treatments depending on the heart rhythm. There are other devices called defibrillators that can be implanted for people at risk of dangerous fast heart rhythms. And there are procedures called ablation procedures where you can actually find the abnormal circuit and you can cauterize it or treat it so that it doesn't cause problems.
Perfect, thank you. So how does a person know if they need to go to an EP or electrophysiology lab?
So there are sometimes they don't know, and sometimes it's picked up as Dr. Reimers alluded to on a routine physical or EKG, which is why it's important to get checked out regularly, because you know, even though you feel good, there can be abnormalities detected on your EKG, which can signal that you're at risk for developing abnormal rhythms, and we can catch them before they become an emergency. Otherwise, the symptoms that can arise, so people often feel their heart racing or beating funny or irregular, or feel their heart pounding or jumping out of their chest, and it can come and go. It can be it can last all the time, or it can be sporadic episodes. And we have tools that can diagnose even if the episodes are sporadic, and that can be a signal of not only an abnormal electrical signal, but it can be an indicator of other heart ailments as well, whether it be decreased heart function or blockages in the arteries. And so that's why it's important to get checked out to make sure that it's not something. And other symptoms people can get oftentimes present with dizziness or passing out. That's something that can be an indicator of an abnormal slow or fast heart rhythm that we have to diagnose.
Excellent, excellent. So can you speak about pacemakers a little bit more? Essentially, how does a pacemaker work?
So a traditional pacemaker is implanted in the chest on the left side of the chest, and is although it can be on the right side as well. There are wires that run through a vein down to the heart, and it basically delivers electricity. It listens for the heart's own electrical signal, and if the heart is not does not have an adequate electrical signal to keep it pumping at a normal rate, it gives a little bit of electricity to replace the heart's electrical signal. Now, there are more modern types of pacemakers that don't need wires, that may be suitable for certain people, but that's the basics of how a pacemaker works.
Excellent. And we actually have one great question here that came through on the Q&A. Do you recommend using watches or self-monitoring products to monitor heart health?
That's always a dangerous question. So I think the watches and the other technologies are getting better and better. And what I would tell you is they are useful, and we've actually diagnosed a number of abnormalities and abnormal rhythms. Many patients have caught their own abnormal rhythms from using those watches. They can be a little sensitive, and they can detect, or they can alert you to abnormalities that may not be significant or serious abnormalities. So while they are good to use, and I think they may pick up abnormalities, if you're otherwise feeling well, it's not, and the watch is telling you something's wrong, or your Fitbit or whatever device is telling you that something's wrong, it's something to go and get checked out. It's not necessarily an emergency if you're feeling well. It's something to get checked out sooner rather than later to make sure that that the EKG is okay, or the other tools that we have that we can use that are more specific and can give you a better diagnosis are okay. But it's the watch by itself, while useful, can also go the other way and make people overly anxious sometimes.
Awesome. Thank you so much. So thank you, Dr. Chowdhury. Now it's time for an interactive poll game regarding some common myths. To play along, you will see Zoom poll questions pop up on your screen. Take a guess and answer the questions, or just watch along with us. Drs. Chowdhury and Reimers will explain the answers as we go. Okay, let's get started. So the first question is, heart disease is for men and cancer is the real threat for women. True or false? All right. All right, so our audience is amazing. 100% of them said false. So Dr. Reimers, can I have you just comment on that?
Outstanding. So look, cancer is a serious killer in this country. There's no question about it. But heart disease remains the #1 killer of men and women in this country. And it has been that way for decades. Cancer is second. So I am not at all saying don't do cancer screening, don't take cancer seriously. It is true. But I think the underlying concept and the myth in our society has been men die of heart disease and women die of cancer. And that's just not true. And women get heart disease. I think that the thing which is tricky is that men start to present with heart disease in their 30s and their 40s, if you can believe that. Women typically do not present with heart disease until after menopause. And then after that, they quickly catch up. So that by the time men and women are 70 years old, their rate of heart disease is equal. And so there's that, plus the fact that, as I alluded to before, diagnosing accurately a woman with heart disease can be tricky because the symptoms can be hard to tell. You need to have a high index of suspicion and order the appropriate objective tests to figure out like what needs to be done, if anything. So congratulations to you all on 100%. Yeah, that's absolutely correct.
Excellent. All right, our next question. Electrical abnormalities of the heart are for old people. I'm too young to worry about that. True or false? All right, the results are in. 100% false. So Dr. Chowdhury, if you could just elaborate on that.
So either they're all cardiologists or really good test takers or well educated about heart disease. So yeah, exactly. So while older people are at risk for slow heart rhythms and other electrical abnormalities, we see many young people present with abnormal heart rhythms. And they're not all life-threatening or dangerous abnormal heart rhythms, but they can be very bothersome. And we do have very good treatments for them nowadays. So even as young as ages that I don't even treat, younger than 18, and sometimes at 8 or 9 years old, you can get abnormal heart rhythms. But definitely in the teens and 20s, and all throughout life, you can get various different abnormal heart rhythms. So take your symptoms seriously, no matter what age you are.
Excellent. All right, next poll question. I will know when I'm having a heart attack because I will have chest pain. True or false? Okay, so the majority said false and 10% said no. So if we could have Dr. Reimers explain.
So it would be nice if everybody had chest pain when they had heart attacks. The simple truth is that there are, as I was stating earlier, a lot of patients who get epigastric, meaning sort of upper stomach pain, and that could be your symptom of a heart attack. There are patients, unfortunately, who have heart attacks, and we call them silent heart attacks because they never even knew they had that or had it. That's pretty rare. I think the key is that if, for instance, if you had epigastric pain and it's not going away after trying something like Maalox or Pepto-Bismol, maybe that's something else. Everybody needs to have kind of a high index of suspicion. And if something's not going away, then, there's no harm in being seen by a physician, because heart attacks can be fatal, right? I mean, 25% of people who have heart attacks don't survive. Why? Because they don't get to a hospital in time. And so I think it's important that if something isn't right and something doesn't feel right, just go and get checked out. I mean, it might be inconvenient, but it's certainly not an embarrassment. And I think it's important, and it's far better. I would much rather have somebody who comes in, and it's a false alarm, than have somebody who comes in too late. And I say, there's nothing that can be done at this point. In other words, the horse is out of the barn. And I hate to say it, but we do see that. So I think the bottom line is that no, not everybody has classic chest pain. If you feel something's not right, just be proactive and take care of yourself. It is your life.
Excellent. All right, next question. Heart disease runs in my family, so there is nothing I can do to prevent it. True or false? Okay, so the majority of our participants said false. Dr. Reimers, can you also explain that one?
As I said earlier, not just because heart disease runs in your family does not mean that you're going to get it. I've seen plenty of people who have mother, father, siblings with bad heart disease, and they have nothing. The genetics are very unclear. And so, is it a risk factor? Yes. Is there something you can do about it? Of course. Don't smoke, exercise, watch your diet, make sure you're not hypertensive. If you are, take the appropriate medications and lifestyle modifications. Know your cholesterol. All the things we talked about before, all those things, certainly help. And so I think, you certainly can make a difference. And again, I want to be clear about this. The genetics are unclear. So just because you have a strong family history does not mean that you will get heart disease.
Awesome. Next question. Heart failure means I had a heart attack and my heart is permanently weak. True or false? Okay, so 74% said false and 26% said true. Dr. Chowdhury, can I have you explain this question?
Yeah, so heart failure, there are many different kinds of heart failure. Heart failure is a word I don't like, but because heart failure often refers to just building up extra fluid due to the heart. Oftentimes that's because the heart is too weak and or is weaker than normal and doesn't pump the blood forward enough so that it backs up and it builds up. You can also get heart failure, by the way, with normal heart pumping function, something we call diastolic heart failure. And I'm just going to address a few different parts of that question. So you can get heart failure or weakness of the heart from heart attacks, but thanks to Dr. Reimers and all of our interventional cardiologists, if you catch those early, initially with a heart attack, you get not only heart muscle that's dying from the lack of blood, but you also get stunning. And if you open up that artery, and if you get on the appropriate medications, oftentimes the heart function that looks very decreased at the time of heart attack can improve over the next few months and improve significantly. Whereas we see people with really severely decreased heart function at the time of heart attack whose heart function improves dramatically or even normalizes at follow-up. So it's important to get appropriate treatments. Now, there's also heart failure not due to heart attacks, which also the same thing. And while you may not necessarily need to have your arteries opened up for that, there are medications which and newer medications and better medications that we have, which have led to significant improvements in heart function in people that we didn't see 20 and 30 years ago. If it's okay with you, Melissa, I'm also going to address a question that came up in the QA.
Yes, please do.
AFib is near and dear to my heart, and there's somebody, one of the audience members asked that they have diagnosed AFib for many years. are they more likely to have a heart attack than a person without AFib? And I will say a heart attack that like we traditionally speak of where it's a blocked artery, no, AFib doesn't necessarily increase your risk of a heart attack. It does increase your risk of other types of things. So people with atrial fibrillation are more likely to have heart failure than people without atrial fibrillation. People with atrial fibrillation are more likely to have other things down the line and are at increased risk for things like Alzheimer's, and they tend not to have as long life expectancy as people without AFib. That being said, that's not everybody, and that's true for every disease that we treat. If you look at diabetes, if you look at high blood pressure, if you look at coronary artery disease, anybody with those issues is as a whole is going to have a shorter life expectancy than somebody without any of those issues. However, that's taken as a group, and for every individual, those projections may not be true for any specific individual.
Excellent. Thank you so much. Okay, next poll question. This pain in my legs and tiredness I'm feeling must be a sign of aging. They have nothing to do with my heart. True or false? Okay, so 92% said false, 8% said true. Dr. Chowdhury, back to you, if you can explain.
I think they caught on to the gist of our session. So I'll take again the two parts of those separately. Pain in the legs. So pain in the legs is something that people often deal with. That I stand all day at work, or I sit all day at work, or I walk up a lot of stairs, or I walk 10,000 steps and my legs hurt. But there are specific types of pains in the legs, especially pain with walking, or pain in the calves and pain in the back of your thigh when you're walking. Every time I walk up a hill, I get really tight calf muscles or really tight thighs. And that can be an indicator of peripheral arterial disease. And while peripheral artery disease is something that we also treat and have specialists who treat that, it's also people with peripheral artery disease are at increased risk for having blockages in the coronary arteries. So just like I say your pipes at home, if you have buildup in your pipes in the sink, you're likely to have buildup in the pipes in the walls as well. The same thing, if you have blockages in the arteries in the leg, you may have, it's likely that you're at risk for blockages in the heart arteries, blockages in the arteries elsewhere. So it's important to get that checked out and get on medical treatment. And as for fatigue is and feeling tired is a very non-specific symptom. And there's a million things that can cause fatigue. But heart disease is one thing, especially atrial fibrillation, as somebody asked about before, is a very common cause where people come and they don't know they have atrial fibrillation. Their doctor picks up they have atrial fibrillation and they say, oh no, I feel fine. And then you get them back to normal rhythm and they're like, oh my goodness, I have so much more energy. I thought I was just getting older. I thought I was just, that was just because I was not being as active as I used to be. And so fatigue is a real symptom and can be an indicator of many different types of diseases, heart disease amongst them.
Great, thank you. Okay, your next poll question, please. My heart is beating really fast. I must be having a heart attack. True or false? So Dr. Chowdhury, this one's going to be for you too. 100% false. Good.
Great, then I don't have to spend that much time answering that. So heart attacks can present with various ways, and a heart beating fast is not the heart beating fast is not a usual presentation of a heart attack. There can be a lot of other things that do present that way. Again, I'm gonna piggyback with one of the QA questions about if you already have AFib, is there anything you can do to make it go away permanently? And so that's a much longer answer than you want to hear from me right now. But There are treatments that we have that can make it go away. You know, our treatments for AFib are what we call ablation procedures for atrial fibrillation, have been present in their current form for maybe 15 or 20 years maximum. They've come a long way in the past 20 years. So I can't give you an answer about permanently, but we have people who have done very well over the long term. That being said, we are still learning more and more every day, every month, every year about how to improve. Our success rates for ablation are not 100%, and they're for atrial fibrillation at least. They are for all comers, maybe somewhere in the 70 to 75% range. In certain people, they're better than that. In certain people, they're worse than that. And so that's a very, AFib is a very diverse disease process and very different. Every person's AFib is very different. And the other question about that, if the AFib goes away permanently, does that return your life expectancy back to normal? We just don't have very good information about that. So we don't have long enough studies and good enough studies to tell us one way or the other. So I don't want to give you a definitive answer on that. I would like to think the answer to that is yes, it improves everything else, but we just don't have the long-term studies for me to definitively say that.
Excellent, thank you. All right, next poll question. I should avoid exercise after having a heart attack, true or false? So 92% said false, 8% said true. Dr. Reimers, can you explain?
So exercise is absolutely crucial. It is just so important. We've learned a lot. Back in the 1950s and 1960s, when we really didn't know what to do with people who had heart attacks, you would be admitted to the hospital and lie in bed for a month, which is the worst thing you could possibly do. So we want patients, I mean, there's all sorts of different types of heart attack, from minor to massive, right? So it sort of depends on how bad it was. But I guess the short answer is, as soon as someone can get back to exercising physically, they should get back to exercising physically. It is imperative for heart health. It also prevents complications like deep venous thrombosis with subsequent pulmonary embolus, or a clot that goes from the leg to the lung. There's all sorts of reasons. Exercise is just really, really important. So yes, we really encourage patients. And I actually have a lot of patients who say to me, well, when can I go back to exercise? And I'll say, give it a week. And then, you're, depending on the circumstance, of course, you can run a marathon if you want, obviously train up for it. But no, there's no contraindication to exercising after a heart attack.
And just to kind of piggyback on that, so we have a cardiac rehab program through Northern Westchester Hospital. Really, it's statewide, but just putting it out there. So whoever has a stent implanted, whether it's a heart attack or not, qualifies. It's like a New York State metric. And if you come and you get your stent here at Northern Westchester, we refer you directly. And typically they'll call you within a month or so. And it's all coordinated with the cardiologist to figure out when the best time is. If you have other residual blockages, they'll wait until that's done before they resume physical therapy. But it's a great program, so it's something to look into. If you want to look into it, you can also call that same number and they'll refer you to cardiac rehab.
I would also just add to what you just said, Melissa, which was excellent, was that if you do that rehab process, you actually learn a lot. You learn a lot about stress management, you learn about, diet and exercise and so forth. And so it's not like you have to do it forever. Even going for several sessions is important, but we strongly encourage rehab.
Right, great. All right, next poll question. I think this is our last. If you have smoked for years and you cannot reduce your, if you have smoked for years, you cannot reduce your risk for heart disease by quitting, true or false? 100% false. Dr. Reimers, anything to add?
So regardless of how long you smoked, I'm not talking about cancer. And there's all sorts of cancer, not just lung cancer, there's head and neck cancer, there's bladder cancer, kidney cancer, you name it. But in terms of cardiovascular health, if you've smoked for 40 years and you quit within 3 years, your cardiovascular risk factor will be as if you never smoked ever. So it makes a huge difference, actually. It is important to quit because it is a very, very modifiable risk factor. The other part of it is there are patients who they just really, really honestly like to smoke. And I say to them, well, if you can't quit, every less cigarette is important. So whatever you can do to smoke less or to quit does have, a significant benefit to you health-wise.
Absolutely. Thank you for that. Prior to transitioning to our pre-submitted questions, I just wanted to kind of go over some general guidelines about COVID-19. So Northern Westchester Hospital takes every safety precaution regarding COVID-19. And just to reassure the community, every patient is tested 3 days prior to surgery, or for us, ambulatory procedures. They have to have a COVID negative test before they can come to our facility. COVID positive surgical patients are done at the end of the day. They're isolated from the ambulatory surgery center and the post anesthesia care unit. They're pre-op and recovered in a designated COVID operating room. All patients and staff have temperature taken and are screened for symptoms prior to coming to work and entering the building. All patients are required to wear masks. Staff wear appropriate PPE, face masks, goggles, gowns, and N95 masks where applicable. And just to make everyone aware, we use a device called Purple Sun. It's ultraviolet light that's applied to our operating rooms just to do a terminal clean whenever a COVID patient is in there. And now, thank goodness, we're able to allow one support person in the ambulatory surgery center waiting area. There's no eating or drinking, and COVID protocols must be followed. Only approved visitors are allowed back in the ambulatory surgery center and in our holding area for cardiac catheterization and electrophysiology. The patient area, so they're allowed in the area to accompany a pediatric patient or someone who needs a family member or guardian assistance. So we try to be as flexible as we possibly can within measure, and obviously respecting our institution's rules. But every now and then, obviously, we have to make certain exceptions, and we take every protocol very seriously. So we want to start answering some questions from our registrants, but we have some great Q&As here that I don't want to miss out on. So one question here I'd like to ask: how can you distinguish between a heart attack and a stroke? Dr. Chowdhury.
So while they both have the same cause, which is usually a blockage in the arteries, one to the heart or the other to the brain. So heart attacks usually present, as Dr. Reimers alluded to, either with chest pain or epigastric pain. Some people can get jaw pain, shortness of breath from problems with the heart. So strokes present as neurologic symptoms. So oftentimes you'll see either muscle weakness or facial droop or things like that. Usually a part of the body is not working properly. People are slurring their speech. So it's usually more neurologic symptoms that present with a stroke.
Okay, great. And then Dr. Reimers, what are the routine tests you should get to check your heart health?
Well, certainly blood pressure, and that should start very young, as well as cholesterol. When I say young, honestly, I mean 18. 18-year-olds can have high blood pressure. 18-year-olds can have high cholesterol. There are people who have a genetic form of what we call hypercholesterolemia or hyperlipidemia, and it's important to know those. No one wants to stick an 18-year-old on medication for cholesterol, but there's certainly lifestyle modifications that you can do. That plus just the education about how to diet and exercise and so forth. Those are sort of the routine things. And then your internist, if they see something that they're concerned about, say it's an abnormality in EKG or a symptom they're not sure what to do with. They would, refer someone to a cardiologist who would then make a determination, okay, do I need to order certain tests to figure out this or that? And it could be, either a referral to someone like me, an interventional cardiologist who's dealing with the arteries, or someone like Dr. Chowdhury, for something like atrial fibrillation.
Excellent.
So Dr. Reimers, I'm sorry, I don't want to open up the can of worms, but I always get asked this question myself.
Yeah.
Do you ever recommend a calcium score?
A coronary calcium score?
A coronary calcium score?
I do, and I'll tell you why. Because it is cheap. There's no contrast involved. It takes a whopping 5 to 10 minutes in a CT scan. Yes, you're being exposed to some radiation, but it's relatively minimal. And if you see, this is a great question, actually. If you see calcium in the arteries, okay, that is coronary artery disease or atherosclerosis, period, end of story. So, and it's funny, it works both ways. This is counterintuitive, but I've seen patients with whopping high cholesterols, and I do a coronary calcium score and it's 0. So 0 doesn't mean you don't have heart disease, but it strongly suggests you don't. In which case, do you really need to have them on a statin? It's a real open question. But the other side of it is, you could have somebody with a normal cholesterol, okay, and they have a high calcium score, and so there's no doubt they have plaque. Maybe it's genetics, okay, and you put them on a baby aspirin, and you put them on a cholesterol lowering medication, and that's by far the strongest thing you can do to prevent future heart attacks. So that's an excellent question, and yeah, I agree with that. Personally, I think that's very important.
Excellent. So just to kind of go into some details, what exactly is involved in someone getting their calcium score checked?
Simple. Ask for it. So, again, these scans tend to run about $150. Insurance will often pick it up. It literally, a doctor will put in the order to have the scan. You go into a CT scanner for about 5 or 10 minutes. Again, there's no IV, there's no dye. And so there's no real danger. I mean, there's the theoretical minor danger of having radiation, but it's more than a chest x-ray, but it's just not that much radiation, and it's incredibly valuable information.
Excellent, thank you. So another great question. So is there a test to know if you have AFib? So I think the panelist is asking because it occurred during surgery, but she never feels it.
So that's another great question. So AFib is, as I mentioned before, everybody's atrial fibrillation is different, where some people can feel every time their heart goes out of rhythm. Other people can be in atrial fibrillation all the time and not feel a thing. And atrial fibrillation is also something that can come on sporadically. So you might have it for 2 days and it goes away, and so you don't pick it up on the EKG, you don't pick it up on even if you wear a heart monitor for a week. So there's not a perfect way to know. We have a lot of tools available. So a routine EKG, if you're in atrial fibrillation all the time, a routine EKG will pick it up. I often do heart monitors that people can wear for a week or even up to a month. Or there are implantable monitors that go under the skin in the chest over the heart that you can wear or that you can have in and often last over 3 years for people who I'm concerned. So oftentimes if people come with a stroke and we don't have another good cause, atrial fibrillation is a common cause of stroke. So we will put in those implantable monitors. Now beyond that, if somebody's concerned that they may be having atrial fibrillation and it's not being picked up on a routine EKG or with a heart monitor, it was asked in a question before, but the newer watches, the Apple watches, the newer Samsung watches, and I think some of the other new watches as well, do a pretty good job at picking up irregular heart rhythms. And like I said before, they may err on the side of being a little too sensitive. So they may tell you that there's possible AFib, even if it's just some extra heartbeats. or some other irregularity of the heart rhythm, it's sometimes better to be, in those cases, to be a little bit more sensitive at picking up AFib rather than missing AFib by not getting any of these tests.
Excellent, thank you. So are there any ways to clear plaque from your arteries other than preventing more buildup by taking statins? And does exercise help eliminate bad cholesterol? Dr. Reimers?
Exercise elevates the good cholesterol, the high density lipoprotein, and that is what takes the bad cholesterol out of the arteries. Now, the unfortunate truth is once you have significant plaque in the arteries, it's never going to go away. It's there for life. So what the statins like Lipitor and Crestor do is they not only lower the cholesterol, which helps prevent plaque buildup, but they stabilize the plaque. So the plaque is less likely to rupture, which is what causes the heart attack and prevent heart attacks. So that, along with the baby aspirin, probably the two things to save more lives from heart attacks than anything else is a cholesterol lowering medication and a baby aspirin, to be honest. But I think that, if you have plaque, there are things you can do to keep it from getting worse.
Excellent. So someone asked, is there a cardiologist that specializes in hypertrophic cardiomyopathy at Northern Westchester Hospital?
There is not right now. There are actually very few people who specialize specifically in hypertrophic cardiomyopathies. What you usually will find is heart failure specialists who, you think, oh, they're dealing with weak hearts, but as Dr. Chowdhury was speaking earlier, a third of hearts are like too strong, and that's diastolic dysfunction. And the minority of those have this disease called hypertrophic cardiomyopathy. So at this point, not yet. I would say within 6 months, the answer will be yes, because we're actively recruiting a heart failure specialist.
Great, great. And so there's one other question here that I think is, I'm sure, very popular, and I think it's important for us to answer. Should you take a baby aspirin every day as a form of prevention, even if you don't have heart disease? Dr. Reimer?
See, that's a good question. This is one of the reasons why getting the coronary calcium score is not a bad idea, because then if you have plaque. Now, aspirin has been also it's been suggested, I don't think there's hard evidence on this, but doing other good things like preventing colon cancer and so forth. There was recently a study saying elderly patients, meaning over 75, should not take baby aspirin if they don't have heart disease. And the point of that was, if you get to a certain age, you're taking a baby aspirin, is there a risk that you're going to bleed? And those are legitimate concerns. I would argue there are not that many people who are over 75 who don't have some level of atherosclerosis somewhere in their body. In general, I think we can say for men, as a generalization, men over 50 should be on a baby aspirin because the downside is so small. You're not going to get an ulcer taking one baby aspirin a day. It's just not going to happen. And women, good question. It comes down to risk factors. I think the easiest thing to do, if there's a question like that, that's a question that should be asked of a cardiologist or your internist.
Excellent. So if we have time, I'd like to ask one question before we get to our final question for Dr. Chowdhury. Does long-term use of stimulant medications raise your risk of heart issues?
Long-term, not necessarily. Stimulant medicines are associated with various abnormal heart rhythms and can raise your risk of atrial fibrillation as well as other abnormal heart rhythms.
Excellent, thank you. So since we're kind of wrapping up now, I just wanted to ask one very important question just to kind of address disparities in healthcare. Someone from our pre-registration questions, they asked, why is it so much more difficult for women to get accurate diagnosis of heart disease than their male counterparts? What is the cardiac community of providers doing to recognize and correct this bias in healthcare?
I think the bias, I'm not trying to disparage any of my colleagues, but I think that cardiologists today are very much aware that women present differently than men. I think that your general practitioner may not be as aware of that. I think if there is concern, if a woman has a concern, do I have heart disease? There's no reason not to seek out a cardiologist's opinion. Cardiologists are, well aware of this fact. And by the way, I'm not saying anything that hasn't been in the popular press. As long as 10 years ago, it was in the New York Times that general practitioners don't pick up heart disease in women, and as well as cardiologists. Well, they're not trained to think the way we do. And I'm not saying anything against general practitioners at all. I mean, there are plenty of things that I don't know that a general practitioner does. So I'm not trying to disparage anybody. I'm just trying to say that I think that if you're a woman and you have concerns, then, it behooves you maybe to get a consultation.
Excellent. Thank you so much. Thank you both, Dr. Reimers and Dr. Chowdhury, for all of your great answers to our questions. We'd like to thank all of you for joining us tonight. Please complete the survey that will pop up on your screen. Your feedback is so important to us. On the survey, if you would like to be contacted to answer personal questions or schedule an appointment, please make sure that you share your name and your phone number. Our providers will contact you. And for all of you, you've submitted great questions. If we didn't get to you, please submit them in the survey. Thank you, everyone.
Thanks, everybody.
Thank you.
Thank
Thank you very much. Take care.
Take care.